Good afternoon. Good afternoon. I call this Committee of Human Services Finance to order. Members, we have a quorum present. Wanted to start with the approval of the minutes for February 2022. Vice Chair Parna.
I would be happy to move the minutes for February 22, 2024.
Vice Chair Parna moves the approval of minutes for February 22, 2024. Any discussions? Hearing none, all those in favor say aye.
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 Opposed? Hearing none, the minutes for February 22, 2024 are now approved. Members, we do have a couple of items that we'll be going through. The first item is the presentation from the Department of Health from Assistant Commissioner Backstrom. Welcome to the committee. Please introduce yourself for the record and proceed with the background studies information.
Good afternoon, Mr. Chair and members. My name is Carol Backstrom. I am an Assistant Commissioner over at the Department of Health. I have the Health Systems Bureau, which is the Division of Health Regulations and Health Policy, as well as the Office of Medical Cannabis. I've been in the role for about 6 months, and I'm happy to be here today. I'm going to talk about some background studies, some information around the Department of Health and our role in background studies and going forward at this point. So first of all, as many of you probably know, background studies are the types of background checks that go on around protecting children, vulnerable adults, and those who receive healthcare services and human services throughout Minnesota. You know, any person who has contact with children or vulnerable adults, such as volunteers, employees, caretakers, anyone who has direct contact or access to vulnerable adults and children, in their professional role must have a DHS background study completed. They're both state requirements and federal requirements. Background studies, of course, determine whether a person has committed an act that would disqualify them from being employed or providing services. And importantly, a background study is more than just a background check. It requires a thorough understanding of information from multiple sources and includes ongoing monitoring. In terms of the Department of Health and our role related to background studies, we have a number of health professions that require background studies that we license in Minnesota. DHS, however, is the entity, the agency who conducts the background studies, and they do it for more, DHS does this for more than 65 provider types, including more than 37,000 individuals. DHS conducts background studies on behalf of the Department of Health and our licensed providers, but also for the Department of Corrections, MnDOT, MNsure, Department of Education, Judicial Branch, Supreme Court, counties, et cetera, and tribes. We have 11 provider types at the Department of Health who have historically had their background studies subsidized. The cost of that background study has been historically subsidized, including those employees from nursing homes, assisted living facilities, home care, and hospitals. And in order to do this, the Department of Health had an interagency agreement, an IAA, with DHS between, the most recent one was for July 2017 through December 31st, 2022. Sorry, we've had one subsequent extension, but our main IAA went through December of 2022, which covered the background study costs for the MDH licensed providers. The total appropriation allocated for this activity covered background studies program, basically the logistics or the systems piece of this, and included costs for the Attorney General's office as well as our MDH staff for reconsiderations, which is still a role that we do, we perform. MDH is the only agency that paid for background studies for its 11 of 15 provider types that we regulate. And in 2022, DHS had background studies that totaled about 507,000 people, or 507,000 applications for studies, about half of which were for MDH licensed providers. And then just going, back to 2021, because there were some legislative changes back in 2021 that I think are important to just point out here. The 2005 legislatively established fee of $20 was not keeping up with the costs of the actual background studies. So in 2021, after extensive discussions with providers, the legislature increased the fee to $42 per study, and then by another $2 in 2023 to $44 each. DHS sought that legislative fee increase to pay for the actual costs of the operations and to ensure compliance with federal requirements. In other words, the system had to be upgraded. And the statutory changes, this is an important piece, the statutory changes in 2021 also created an obligation for providers, licensees, and other professions licensed by MDH to pay DHS directly for those studies. And despite that, though, the legislative language for directing payment, MDH continued to pay for the background studies per the interagency agreement that we had with DHS at the time. No changes were made to the interagency agreement after that 2021 legislative change until the amendment increasing the fees to $42 per study, which was effective for calendar year 2023. So in other words, we extended our interagency agreement with DHS for 1 year that went for calendar year 2023. So now, fast forward to 2023. Well, first of all, I'll just cover 2021. So we had that contract in place, an adequate special revenue fund to cover the costs of the studies, which ran through December of 2022. At the end of 2022, though, we extended that contract for 1 more year in anticipation of doing that transition from subsidizing these costs to having providers pay for them directly. We started planning with DHS and talking about the improvements that would need to be made to the system so that DHS could take payment directly from providers. So that was all in 2020. We started talking about that in 2022, and then now in 2023. Let's skip this slide if you don't mind. Last year in our budget request, we requested and received the increased funding from the legislature as part of our regular budget request to cover the anticipated increase for 2023 through fiscal year 2024. The amended appropriation was for an additional $2.8 million based on the DHS identified average of about 9,000 studies per month at $42 per study. However, the next sub-bullet there, actual background studies initiated was identified to average about 13,600 or so studies per month. So in other words, we underestimated the number of studies that were actually occurring. MDH, we immediately identified that the requested funding at the beginning of calendar year 2023 was insufficient and requested an additional appropriation out of the special revenue fund at the end of 2023 to cover the estimated costs for the increased the number of background studies. So backing up to the summer and then this fall, just in preparation for the transition, DHS improved the system or upgraded the system in order to accept direct payment from the MDH licensed providers. So that took some time. And then the Department of Health, we sent a Gov Delivery advisory to all of our providers in October of 2023 to announce that decision to transition providers to paying for background studies directly, effective February 1st of 2024. And that a new 5-year interagency agreement took effect on February 1st of this month. So with that, I will just stop there, just to point out that the new interagency agreement does not include any dollars that are exchanged between the Department of Health and DHS because of this transition to direct provider payment. Any questions?
Thank you so much, Assistant Commissioner. And member questions or discussions? Representative Zalesny.
Thank you, Chair, and thank you for this information. It looks to me that there wasn't much notice to providers of this $44 cost. And do you have any studies to show what the impact is for the providers based on how many background studies they did in the previous year on what the budget impact is?
Assistant Commissioner.
Mr. Chair and members, we have the estimate, we have the estimates of how many background studies we have been paying for in the last, through calendar, all of calendar year 2023, which really shows the uptick of the studies. There are definitely duplications or numbers that reflect where a background study has been initiated and then perhaps initiated with another employer. So for example, there's multiple studies that are being initiated for a single individual. So there is definitely a cost to that. And then the first question in terms of notice, I think, if I'm not mistaken, in 2021 where the increase in the fee was discussed, I think providers were very aware that the fee was going up. And that the 2021 legislature directed the payments to go directly to be paid directly from providers. In terms of the transition, yes, we notified providers in October of 2023, providing about a 4-month notice.
Representative Sneaker.
Thank you, Chair, and thank you, Commissioner. I guess my observation of this is for those that are running 24-hour operations, that is way past their budget cycle. And just doing quick math, it could easily be $1,000 for a small facility a month. And so you just look at those costs for what the provider's going to be paying. And I think that that's a big hit for providers when we already have nursing homes. We've had more nursing homes closed since we last left session last year. And so we have this is a huge issue on the background studies, and I guess my ask would be to delay this and have at least have a transition time. I don't know what the language said if it was in discussion between DHS or MDH, but I can tell you the sites do not do budgeting this way. And so while this might seem like a very small increase to the state, it's not to the facilities, and we're just going to have further erode the financial status for assisted livings and nursing homes across the state of Minnesota and other entities. So I think it needs to be taken into consideration because the industry is extremely fragile right now, and the number of applications for these background studies is just showing how unsteady the ground is for the workforce, because that's showing you how many open shifts facilities have that they're trying to staff. And so they're not only having the cost of the background studies, they're also having the cost of trying to get the workforce in. So I would ask for a delay of this or consideration from this committee. Thank you.
Chair Fisher.
Thank you, Chair Noor, and I appreciate hearing the concerns that Representative Zelenska raised. Was wondering, as I know under the nursing homes, there's they go through the reimbursements where they're eventually paid for their costs. Is this one of the costs that they get reimbursed for eventually? Is for the question I would have, and I don't know who would be.
That's the question for DHS. I don't know if the department will be able to, or rather, are they paid through the MDH process?
Mr. Chair, historically, again, there has been a subsidy provided by the state for the cost of these studies.
I think we'll wait for DHS to come and give us that update. We'll follow up. We'll give them the time to look into that. Maybe we'll get another time. Lead New Brindley.
Thank you, Mr. Chair. And thank you for the presentation. I was trying hard to follow it. As I was listening, though, my understanding is that one of the reasons that this is the way we've been trying to do it is to try to reduce duplication. And you addressed duplication a little bit, and I don't understand. Do you have a mechanism in place to track duplicative requests? I mean, I think that's the point of, or at least one of the intentions of doing it this way, is that you are a central clearinghouse. And, if there are multiple facilities requesting on the same person, what's the process? Are you finding those and just producing one report that can then?
Assistant Commissioner.
Mr. Chair and members, I'm not able to answer that. I mean, the Department of Health really served as sort of a fiscal intermediary for the purpose of subsidizing the providers that we license. That question would probably need to be addressed by DHS in terms of the actual studies and the process.
I can tell you that we do have a bill that actually addresses the duplicative, background studies. And so we'll be talking more about it. Lead New Brinley.
Thank you, Mr. Chair. I appreciate that. It feels like that would be a very basic question that we should come prepared to answer in committee. The other question I have, you indicated in your slides that you expected 9,100 studies per month, and you saw an average of 13,690. Why were your numbers so off? Like, why? That's a 66% difference. Those are just wildly inaccurate numbers. How did you come to those numbers, and why the explosion and not being able to anticipate that?
Assistant Commissioner.
Mr. Chair and members, again, we don't know the exact reason for the increase in 2023. We agree that it was unanticipated and much higher than we thought it would be. We were basing our information on historical data. I do think that there were some, the investment that was made on the part of DHS in upgrading the system was to comply with federal requirements, and that there's a cost there, for one thing. But again, sort of the charge hits the system for every initiated study. And again, the numbers, the only theory we have really is around sort of the number of initiated studies. For example, when someone starts a study and maybe didn't submit their fingerprints, for example, and they go back into the system to submit the fingerprints, my understanding is that it has to do with the number of touches to the system that initiates the fee.
And also the programs that we increased will initiate more studies anytime that there's somebody new starting the work. Lead New Brinley.
Thank you, Mr. Chair. And again, that should have been anticipated. Like, if we're mandating additional things and we're paying for additional people, that we should be able to anticipate that. My question is, and maybe nonpartisan staff, maybe Mr. Berg can help. I'm wondering if you can just tell us, if you can remind us what the DHS budget was for last year. And I'm wondering, even if we look at, we gave an appropriation for almost 3 million. An additional appropriation would be less than 2 million to cover 66%. And I'm wondering what our total appropriation was last year for DHS.
Mr. Berg.
Madam Chair, I actually don't have the 23 number in front of me, but I am looking at the 24 numbers, working on something else. And DHS's total net of federal reimbursement is $10,392,237,000 in the current year. It would be somewhat less than that for 23.
Thank you, Mr. Chair.
Lead New Brinley.
Thank you, Mr. Chair. So it seems like the less than 2 million is probably, we could find that somewhere. Thank you, Mr. Chair.
I have Representative Kutizotun.
Thank you, Mr. Chair. And I actually have a little bit, maybe following up on Representative New Brinley's question about the duplications. Can you just kind of walk us through how this system works? Because when I log into any given website, it's always asking you to log back in, or, when I applied for a passport, it's always, they're like, continue your application. How does it work? Do you have to go through and select what employer you're applying through so that somebody could create a secondary or tertiary, however many applications they're submitting through the system, or is it under the person's name and email? Because it seems like that would be a very simple way to do it, and perhaps the bill that the chair mentioned is addressing that. But if it's based on touches and how many times people go into the system, that there has to be a way for us to fix that.
Assistant Commissioner.
Mr. Chair and members, again, I'm unsatisfying answer, I understand. I'm not in a position to be able to answer that. Again, the Department of Health sort of served as that fiscal intermediary, and it sounds like this bill you might have a chance to dig into that a little bit more.
Representative Quam.
Thank you, Mr. Chair and committee members. The talk about reimbursement and the timing, et cetera, the financial straits that a lot of the entities are suffering, it doesn't help if we're going to reimburse you and the money shows up in a couple of years. We need to find ways of, if we have to charge them, transfer from the department to them, that it's closer to real time, because cash flow is one of the main issues they're hitting, and they have to take out loans to do payroll for cash flow. So we must keep in mind with any legislation we do to cover that. And on the background check thing, I remember a few years ago, we had issues of where people that retired from certain activities, but they went back and covered vacation at multiple entities to give some of their former coworkers a break and still be a little bit active in helping people. And at that time, if they did it across sites in multiple counties, they were having to do multiple background checks. So if we ever touched this area of activity, we need to make sure that if a background check is done, we can utilize it, across different agencies or counties or groups. We need to look at globally of doing things smarter and easier, because we already have big problems. But thank you.
Thank you, Representative Quam. Any other member questions? So, Representative Baker.
Thank you, Mr. Chair, and again, I appreciate the presentation. I guess I am a little surprised if we're going to talk about this information. I really want to kind of dive into some of the questions that have been asked already about logins and duplications and finding out why is this blowing up on us. In your report, I didn't see any mention about what is the average time now of getting a response back on backgrounds. Has that been improving over the years? Has it been delayed because there's 60% more, 40% more? What's happening to the turnaround? And also, again, we need to have a discussion more about how does this actually work? Because we all have one social security number. We all have one certain thing that we can't change, whether it's an email or whatever. People smarter than us sitting here have figured this out about not getting the duplication, so people are bypassing a safety net that we need to protect. I need to know, if it's not you, Assistant Commissioner, it needs to be somebody before we kind of really dive into this further, because this is really important. But if you could tell me the turnaround time, if that's improving, and who would you recommend having us in front of the committee sometime?
Assistant Commissioner.
Mr. Chair and members, I don't know the answer to that. So it sounds like it needs to be a part of the larger discussion.
Representative Zalesnika.
Thank you, Chair, and thank you, Assistant Commissioner. Having spent 30 years of my career in licensed facilities that require background studies, this is the most cumbersome, clunky process for anyone to get a job. At a time when we have the greatest workforce issue, and we are caring for vulnerable adults. I mean, let's remember who we're taking care of in disability homes, group homes, in hospitals, in clinics, in our nursing homes, assisted livings, and we can't even get the employee to put into orientation to train. And that's not my responsibility anymore, but it was for 30 years. And it wasn't simple before 2020. And when I look at these numbers, in addition to having costs transferred to them for mandates that this body sets for them, we are setting them up for failure at a time when we can see that they're already failing. And so this is, childcare. There's every aspect that we're trying to do to ramp up the workforce is being affected by this background study. And I don't know why it's this hard. We have numbers for lunches, we have codes for students, we have a medical record number, why we have a social security number. How is it that with the IT technology that we have today, we cannot track a process faster to get people through a system without duplication and without delays? Because people are not going to drive 60 miles to get a fingerprint for a $15 an hour job and then wait a month or 2 months till somebody tells them they're eligible to work. They already needed a job a month before that. So we have to find some true viable solutions. And this chart is extremely disturbing and shows the problem. And this is, it's a barrier to employment. It's a barrier for the people to get a job. And they're quite frankly going to go to Costco or somewhere else than work in healthcare if it takes this long and is this cumbersome. We're asking way too much of providers and way too much for the people. Thank you.
Representative Gilman.
Thank you so much, Chair. So just quick question. Could DHS come down and answer a couple of the questions that were asked? Are we allowing just a couple minutes for that?
They're tracking the data, so we make ask them to come later to provide us that update.
Like later another day or later today? I'm just curious.
I think another time.
Okay.
Because they were not prepared to give that
Okay.
information. So let's give them the time. Maybe they can send us via email in terms of how the cost analysis. It's the VBR process. You know, we've talked a lot about it last session. So I think let's give them the time to figure out if that is included in the reimbursement process.
So one other quick question. Yeah, and then, yeah, I would love the public to know that as well, because there's big things with that. Secondly, is there somebody that we could talk to from long-term care, for example, that would have information on how long it takes? If they have someone, one thing that we're doing really well in Minnesota is like long-term care facilities are able to get CNAs on board and start hands-on training, help them find success right away on the job. And other places around the nation are looking to Minnesota at like, how are you finding success with getting folks in and you're getting things done in a lot faster space, like in a shorter space of time. I can't say the words right. But the one thing that they're having issues with is if there's someone from long-term care, even that could just give an example. I've heard in my district that it could be over 6 weeks or more that they're getting their background check done. And what's crazy is that we have the numbers that have gone up, and we've heard you say that if they're clicking on it again, it's probably just, getting another charge, things are happening like that. The inefficiencies with that and also the cost to folks. But I'd love to know if there's someone here that could answer, how long are you waiting for a background? If there's somebody here that could answer that, I don't know.
It's a good question. I know every background study is unique, and I don't know who has that information. This will be a whole discussion if we start talking about the whole background studies. Maybe we need to.
I think we do need a whole discussion, though.
I
do. I really, at some point, I would love that.
Lead New Brittany?
Thank you, Mr. Chair. I appreciate you navigating this right now because it's a little tricky because, frankly, for the public, this is sort of peak government. Holding a hearing on DHS background checks and DHS not being able to answer questions on DHS background checks.
This one was MDH. I think also, DHS were not included in this discussion. It's the funding that went through as a pass-through to MDH to pay. And quite frankly, it's a legislative problem because we need to be looking into the funding process. If we can fund directly through DHS with the Net Study 2.0 system, I think this can be streamlined in a different way. So we need to find the legislative solution to a problem that we are hearing right now, because it comes down to, do we have the funds to pay for background studies for the programs that are licensed by MDH? So as you're aware of, we've got programs that are licensed by MDH, but the payment usually comes from DHS. And there are programs that are licensed by DHS and the payment comes from DHS. I think that's a conversation for another day. But Lee New Brinley, if you wanted to help us and guide us, maybe you can come up with a solution that we can solve this problem.
Thank you, Mr. Chair. It would be helpful if when we're talking about background studies, if people could talk about background studies. That'd be a good start.
Appreciate
Thanks,
that.
Mr. Chair.
Anyone in? So I don't hear anyone else. I think we'll follow up with DHS in terms of the background studies and the cost related to payment process to nursing facilities and others. Did you have any closing comments or departing statement? Because I know this was put on your shoulders, but if you wanted to guide us where we can go from here.
Mr. Chair and members, I look forward to the continued conversation. Thank you.
Thank you so much, Assistant Commissioner, and we'll follow up on that. So we've got a lot of things to do under the background study. A little bit switching here to do the second bill, the first bill.
All right. Mr. Chair. All right, members, we do have before us HF 3643. And with that, Chair Noor, would you like to move your bill?
Thank you, Madam Chair, and members. I'd like to move House File 36, I believe 3643 to Health, Policy and Finance Committee.
Wonderful. And then now that we have it before the committee, we do not have any amendments on the bill, so we're going to go straight to testimony from Chair Noor.
Thank you, Madam Chair and members. This bill is related to the Emergency Medical Assistant, or EMA, which is the current healthcare program that exists to cover emergency treatment and services for Minnesotans who have basis of medical assistant eligibility, except that their immigration status may not allow them to qualify for medical assistance. Members, EMA covers the care of treatment and emergency medical conditions provided in an emergency department or in an inpatient hospital when the admission is a result of an ED admission. Members, consistent with the federal law, EMA covers some care and treatment provided in other settings as well. This applies when a patient medical condition without care is expected to result in serious impairment or when places the person's health in serious condition or jeopardy within 48 hours. In this situation, members, EMA will cover these services only if they're part of approved care plan certification. There's currently a process through which these services must be approved. However, in practice, there are issues that exist in EMA. What this bill aims to address are challenges where nursing home may not accept a patient who is eligible for EMA, but their customized living settings or group home or other settings that they may be able to go to. Members, we've talked a lot about the acute care transition and inability to transfer a patient from the hospital setting. This is exactly why we have this bill. EMA is allowed program under the federal rules, and by passing this bill will ensure that individuals who are seeking services, who are staying longer in hospital, can be moved to a different facility. With that, members, I think this is my intent with this bill is to save costs. I know there's a lot of discussion ongoing to make sure that this can be allowed under the federal rules to ensure that the patient who's transferred to a different setting rather than staying in a hospital can be covered for the same services, which otherwise will be lesser than the cost in a hospital setting. Madam Chair and members, I do have a testifier on this bill to guide us through that process.
Thank you, Mr. Chair. And would Amanda Bozer please step forward? And Ms. Bozer, when you're prepared, if you want to go ahead and state your name and your affiliation for the record, and then go ahead and proceed with your testimony.
Great. Thank you, Madam Chair and committee members. Let's see here. My name is Amanda Bozer. I am the supervisor of social work in the inpatient and emergency department at Hennepin Healthcare, and I am speaking in support of House File 3643, which would improve EMA coverage. A big part of my role and the role of my team is to help those who need it find a safe place to go following discharge. You have heard about the many challenges with people remaining in the hospital far longer than they need to, which results in being over capacity and sometimes being unable to accept the trauma patients and other patients who need our care. What Representative Noor outlined as a network adequacy issue within EMA is a challenge we have faced in being able to discharge patients to the right level of care at Hennepin Healthcare. EMA helps patients who are in dire need of healthcare when they are at our front door. Some examples from the last few months include one patient who had suffered multiple strokes, who was able to get treatment to repair damage and avoid future strokes, or another patient who was dealing with severe debilitating headaches, who finally sought treatment only to find they had brain cancer. This bill focuses on when patients are at the back door and trying to leave the hospital for a more appropriate level of care or a place to live. One patient stayed in our hospital for 9 months without a medical necessity. because of this exact network adequacy issue. An 85-year-old Somali patient with dementia who qualified for EMA was stuck in our hospital because we could not find a skilled nursing facility that would accept them due to one past aggression, which can be typical behavior for someone with dementia. In our search to discharge them to an appropriate level of care, we found a customized living setting that was ready to accept them, spoke their language, Oromo, and was able to meet their medical needs. However, the state could not pay for this using EMA, even though the customized living setting we identified would have cost at least 75% less than a hospital level of care. They spent 9 months in our hospital, for which the state paid over $500,000, based on the estimated daily cost of around $2,500 per day to be in a hospital when they do not need to be there. We took on the responsibility of paying $500 a day for that patient in the customized living setting, ultimately because we knew it was the right thing to do. Hospitals are not a place for people to live. And unnecessary hospital stays can lead to irreversible decline in functional status and negatively impact physiological well-being, especially for vulnerable adults and children. The total cost we paid for them to live in that customized living setting instead of the hospital for 9 months, which is around the same amount of time they stayed with us, was $136,000, saving the state nearly $500,000. By making this modification and broadening the settings available to a patient who already qualifies for EMA, by permitting certain long-term care services to be covered, will not only support getting patients to the level of care they need, it will help relieve some of the discharge delay challenges we are facing when a patient has complex care needs. I appreciate the opportunity to speak today in support of this bill and respectfully ask for your support of House File 3643. Thank you.
Thank you, Ms. Bozer. And with that, we do not have any other testifiers on the list. However, I do want to ask the public if there is anyone here that would like to testify on behalf of this bill. All right. Seeing none, we will move to member discussion. Representative Quam.
Thank you, Madam Chair. And to the author of the bill, we've heard about this general issue of, being in the hospital and not having places to go. It'd be nice to look at if we've got data for the last several years and then maybe the trend, monthly data for the last 12 months so that we can see, because we've tried a few things over the last few years, see what has impacted it and try and come up with a general solution. This is aimed at a small portion, but if we can address the background cause and issue more generally, it probably will free up funding to better, cover these issues both in this bill and more broadly. So the chair of this committee maybe could get the whole committee some information offline, but I like your intent of doing things smarter and more intelligently. I just think we need to do that globally. Thank you, Mr. Chair.
Thank you for that. I do want to say, and I'm not sure if I think all members are getting it. I know that Susie Emmert from Hennepin Health has been sending regular reports on boarding issues within their emergency department. I'm not sure if you received those, Representative Quam.
Thank you, Madam Chair. That's one entity. We've got a broad state with some very diverse differences regionally, especially where there are certain communities. St. Cloud has some special cases. So instead of just saying, well, we get the information from this entity, I want us to understand the state and globally address the problems that we face across the state.
Thank you, Representative Quam, and I appreciate that. Sorry? Oh, Representative Wattoon.
Thank you, Madam Chair. Just a quick point of clarification. I think it might only be the Hennepin County delegation that receives those emails, but it might be of interest to this committee in particular.
Okay. Thank you for that. And agreed, I would actually love to see more. I hear about it from entities in my particular area as well, up in Maple Grove from North Memorial. I don't always receive a consistent report from them, but it would certainly be helpful to have more of that information. Thank you. And with that, Lead New Brindley.
Thank you, Madam Chair, and Chair Noor, thank you. My question is, do you know statewide what percentage of patients who are beyond medical necessity in hospitals, so this is our decompression issue, right? Do you know what percentage of the patients statewide would be affected by this change in legislation? And again, I'm thinking that narrow population of folks who are beyond medical necessity of being in a hospital, but we know, I mean, decompression is an issue across the state. How many of those patients statewide would be affected by this change?
Mr. Chair.
Thank you, Madam Chair. Thank you, Lead New Burnley. It's part of the fiscal note request, how much we're paying for when it goes to the health, because it's going to be under their jurisdiction. So I'm hoping that we get the data in terms of how many people, but I think you've had from my testify, there are a couple of individuals who are utilizing Hennepin Health who have been impacted directly. And the cost is significant, as you've had, spending thousands compared to spending 25%, we're spending 75% more.
Lead New Brindley.
Thank you, Madam Chair, and thank you, Representative Noor. I'm glad that will be part of that fiscal note. I would just suggest that this decompression issue is much bigger than this very small population. And while I understand that I'm sure that Hennepin Health is particularly affected by this particular population, this is a massive issue we have statewide, and I would hope that with whatever small funding we might have available in our human services target, if we end up with one, that we would look for a broader approach to deal with decompression that is going to help hospitals across the state and not sort of in this unique situation. Thank you, Mr. Chair.
Mr. Chair, did you have any comment you'd like to add?
I just wanted to know, Madam Chair, note that we will have the hearing and discussion about the acute care transition, and there'll be more conversation on that separately.
Thank you. And I do know that that is an ongoing conversation with many hospital systems currently. Representative Zalesnikar.
Thank you, Chair, and thank you, Chair Noor, for bringing this to the committee too. I understand the situation. I've been following Hennepin County, been on many of their calls and listened, and also talking to hospitals across the state. I mean, the decompression issue is real. The cost savings, it's typically what we've always said is MA pending status for many people, and getting this paperwork completed in order to have a payer source so the next place can provide services. And so it is not a new issue. It's a heightened issue. And I think the other thing we have to talk about is the other reason why they are sometimes holding people for months is the care needs of these highly acute people with multiple complex care needs. Seniors, they are not able to take the patient because they don't have what we just talked about, the workforce. And in order to have the staff in the facility, that it costs less than the hospital, you have to have the workforce in the nursing home or the customized living setting. And so it's the chicken or the egg thing. We have to make sure that we have this background study thing taken care of, or we cannot get the decompression from the hospitals done. Because when they're looking at a care plan and looking at the needs in the hospital noted, and they do one-on-one staffing for somebody with high behavioral needs, and you don't have the ability to staff that, you cannot take a patient. The MDH guidelines are very clear on your responsibility to that patient when you admit them. And so that is part of the problem that we're having, and that has to be addressed too. And so I I think it goes back to the first thing we talked about too, but I understand and appreciate what you're doing, Chair Noor, and it's very important. Thank you.
Thank you. All right, and I don't think we have any additional comment there. Do we have any additional members that would like to speak or have questions? All right, seeing none, the intent here is to, in fact, move this along to the next stop. So with that, hearing no further discussion, Chair Noor will renew his motion that HF 3643 be referred.
Madam Chair,
Yes,
can I request a roll call on this, please?
a roll call being requested. We will take one. And just to finish, we will now renew the motion to put House File 3643 be referred to the Health, Finance, and Policy Committee. And with that, we will take the roll.
Chair Noor,
Aye.
Vice Chair Bonner,
Aye.
Lead New Brindley.
No.
Rep Baker. Rep Cardy.
Aye.
Rep Fisher.
Aye.
Rep Franson. Rep Gilman.
No.
Rep Hicks.
Aye.
Rep Keeler.
Aye.
Rep Katiza Watoon.
Aye.
Rep Pryor.
Aye.
Rep Quam. Rep Vernig.
Aye.
Rep Zelensnikar. That's 9 yeses and 5 nays.
Okay. And with that, with 5 yeses and 5 nays, that is in fact,
Madam Chair, with 9 ayes and 5 nays.
I'm sorry. Sorry about that all. Nine ayes and 5 nays. The motion has been confirmed, and we will be referring that to the Health, Finance, and Policy Committee. And with that, we will switch back. Chair Noor.
Yeah. So the next bill is Rep Hollins, but we're waiting for the public who are exiting. Yeah. Representative Hollins, welcome to the committee. So we have House File 3990. I move House File 3990 to be re-referred to Health, Policy, and Finance. With that, please introduce your bill.
Okay. Thank you so much, Chair Noor. Thank you, committee members. Happy to be here. Hopefully this will be very brief because now everybody's left. But I am here to introduce a bill that removes the duplicative background studies, and I am going to have my testifier explain the need for this bill.
Please introduce yourself for the record and proceed.
Hi, Chair Noor, members of the committee. Thank you for this opportunity today. I'm Sam Sands. I'm the Executive Director of the Minnesota Board of Psychology, but I'm here representing the Health Professional Regulatory Boards. And we've collaborated with the Department of Human Services on the language in this bill. So House File 3990 is really a funding change to a 2022 bill that eliminated a duplicative background check. The original 2022 bill eliminated a second background check conducted by DHS for individuals who already went through a criminal background check as a part of their licensing process here in Minnesota, in certain Minnesota facilities. Prior to 2022, an individual would seek licensure, would get this background check as a part of our process, and then undergo a second background study when working at certain MDH facilities. Often this second background check was conducted within a few weeks or maybe even days of the first. The 2022 bill decreased barriers and delay for Minnesota licensees filling a healthcare need in the state. So it was a good change. And the 2022 bill also authorized special revenue funds to be transferred from the health professional regulatory boards to DHS to modify their internal database for implementation of this law. For those of you that do not know, the health professional regulatory boards collect all of our revenue from licensing fees. So no general fund appropriation is given to the health licensing boards. Therefore, the special revenue funds authorized to be transferred for the DHS database fix were and are collected from our state's healthcare workers, licensed healthcare workers. The funding mechanism places the financial burden of removing this duplicative check on the licensee or our state's healthcare workforce. In addition to the burden healthcare workers face, some of our licensees do not typically work in these MDH-approved settings where they would require a second background check, but they were still included in the 2022 statutory change. So for instance, veterinary medicine licensees are forced to pay for a service that they don't use with a portion of their licensing fees. So HF 3990 changes the funding source from a DHS database modification to the general fund from the special revenue fund and reimburses the boards for the monies that we've sent to DHS for this database update. Under this bill, DHS will continue to receive the money it needs to support the database changes and continue this important work. Licensees will continue to pay for the background check that they need at licensure, but will not be required to pay for the portion of their fees to DHS for the service they no longer receive. So the boards support the passage of this bill and are available to answer any questions you might have.
Thank you, Mr. Sand, for your testimony. Just wanted to check with Mr. Berg with the special revenue fund payment in under what you call 1.13.
Mr. Chair, members, I guess I would summarize this very simply, which if you look at Section 2, it repeals the 2022 law. What this does is it does the exact same amounts as the 2022 law. It just does them out of the general fund rather than the state government special revenue fund, as was mentioned. The reason in paragraph B of Section 1 that it's a transfer is because that is for fiscal year 23, which is a closed year in the state budget system. So ordinarily, we might just go back and amend the law to just switch the fund, but you can't do that in 23 anymore, so there has to be a transfer. Otherwise, what this bill does is simply swap general fund money for in this bill for what was state government special revenue fund money in the 22 law that's being repealed.
Thank you so much for that. Any member discussion? I know we talked about how we address the duplicative background studies. Maybe this is a starting point to make sure that we address duplicative background studies. It's not only for programs under the MDH, we're looking across the board for DHS, even for the childcare system, because it impacts many providers when it comes to the background studies. I see Representative Hicks.
So as you all know, I had my respite bill up in Human Services to expand respite care. And one of the sticking points around that bill is background studies. And so I'm not sure if everybody knows, but I have been learning a lot this week about background studies. And one of the things that I'm learning is that each type of license has different scopes that are federally set by the FBI about what information we can recall for different licenses. And so that's one of the reasons it gets so sticky. It's not really relevant to this bill, but since I have been diving into that space around my respite bill, I wanted to share my learnings with everyone else. So like all great things, it's the Fed's fault.
Representative Kwok.
Thank you, Mr. Chair. My suggestion is that we ask for a consolidating exemption so that for the same type of caring, you're caring for children, you're caring for adults, you're caring for people in group home settings, that we come up with the appropriate background study, get an exemption from the feds to have one that works across, because I would like us to move towards a commonality so that if a person is burning out in one of the care settings, they can go to another care setting with minimal additional training and be able to continue working to help people. This is something that's far beyond what we could cover today, but I think to keep in our back mind and in the future, we should look at, again, how to do things better and avoid, the duplication or other issues that keep us from maximizing the good we can do with the people we have. Thank you, Mr. Chair.
Thank you so much. Lead New Brinley.
Thank you, Mr. Chair, and thank you, Representative Hollins. I just want to level set really quickly. This bill literally doesn't make any changes to how we are managing duplicative background studies. It makes zero changes. It only changes the funding source, correct? So, thank you. My question, Representative Hollins, is do you know how much money is sitting in this state government special revenue fund right now? What kind of money is sitting in that account?
I was going to check with the nonpartisan staff.
Mr. Chair, Representative New Brinley, I don't know that number off the top of my head. My colleague, Joe Harney. Broadly, this is all in Representative Liebling's jurisdiction, which is why this bill is going there. Mr. Harney could tell you what the balance of the fund is. The fund is not in negative at this point. I'm aware that it is not currently got a funding problem. I believe the testifier, you got to the idea, which is SGSR is from the licensing fees largely. And so this is a use that I think they see as outside of the proper use of that fund. But the fund is not in deficit. We're not doing this, I think, because the fund has a funding problem. It's an issue of whether it's the appropriate source for this or not.
Lead New Brinley.
Thank you, Mr. Chair, and thank you, Mr. Berg. I appreciate that. Was really helpful. So really, what this comes down to is, should this money trying to prevent duplicative background studies, is it appropriate to come out of licensing fees? And frankly, if there's plenty of money in that account, and hopefully we'll find that out in the Health Committee, it seems like it's an appropriate use. And it seems like we all probably want to be careful about pulling money out of the general fund, especially, I mean, we may find out something else in the near future, but it just seems, it doesn't make a lot of sense to make this transfer out of the general fund when these funds are available. It's already licensing fees, which seems very related to background checks. It seems like it would be an appropriate use of the fund. Thank you, Mr. Chair.
Thank you so much. Any other member discussion? Seeing none, any closing remarks?
Thank you for your time today.
Thank you so much. So I renew my motion that House File 3990 be re-referred to Health, Policy, and Finance. All those in favor, please say aye. Aye. Opposed?
No.
With that, I think the motion prevails. You are on your way to help. Members, we don't have any other agenda item for today. I just wanted to say we are now adjourned.